reforms and redesign the denture bearing area to create an oral environment to support a functional prosthetic appliance. There is a functional prosthetic appliance. Okay, so what pre-prosthetic surgery do? It reforms and redesign the denture bearing area for that. Okay. So what are the basic aims and objectives? To provide adequate bony and soft tissue support, to eliminate of pre-existing bony and soft tissue deformities, establishment of correct vestibular depth, correction of maxillary and mandibular ridge relationship, relocation of frenal, maybe a labial frenum or a lingual frenum, and muscle attachments and mental nerve. What are the various causes of bone loss? Metabolic factors such as vitamin D deficiency, hyperparathyroidism, Cushing syndrome, renal osteodystrophy, aging, periodontal diseases, disuse atrophy. Sometimes when the patient is not wearing any denture or anything onto the ridge start resolving because there is a continuous process of osteoconduction in the ridge. Okay, there is a deposition of the bone also. There is the resorption of the bone also. So what is the pattern of bone loss? According to Talagan in 1972, it is maximum in the first year of the denture wearing. The bone loss is maximum in the first year of denture wearing. Greater bone loss in the mandible than maxilla. Direction of resorption, maxilla on the buccal inferior portion and mandible in the downward and outward direction. In maxilla, buccal inferior portion, it will resorb. It will resorb, start from the area of sinus. Okay. From both the sides, it will resorb. From the sinus also, the ridge will resorb. In edentulous bone loss up to 1 millimeter per year. Greatest within first 12 to 18 months after extraction. So it is nowadays it is a protocol that either after extraction, if you are planning later on prosthesis for the patient, okay, you should give bone graft. You should give a bone graft. If the site is not infectious, if the site is having any infection and all, then don't give a bone graft. And plan your extraction that the patient is ready for the implant after the extraction, so that the implant heals uneventfully. Put your implant 1 millimeter below. Put your implant 1 millimeter below. So this is the extraoral feature, that long face, more alveolar bone height than short face. Okay. The resorptive pattern of the edentulous ridge. Type 1, minor ridge remodeling. This is the main classification. Minor ridge remodeling. The ridge is wide enough at its crest to accommodate the recently extracted teeth. Type 2, sharp atrophic ridge. The ridge becomes thin and pointed. Type 3, basal bone ridge. The pointed ridge flattens to the level of the basal bone. Type 4, the basal bone resorption. The flattened ridge becomes concave as basal bone resorbs. Correct? Now, what is torus palatinus? Have you heard of torus palatinus?
Yes, extra bone on the palate.
Yeah, it is the benign, slowly growing, bony projection of palatine process of the maxillae and occasionally of the horizontal plates of the palatine bones that occurs bilaterally along with median suture midline along with medial suture on the oral surface of hard palate.
It's very common here in Malaysia.
Okay, it is not common here in India.
I know, I studied there.
So here deep palates are more common.
Oh.
Deep palates are more common. So lot of narrow arches are there. So in orthodontic practice, mostly we expand the arches. Okay, expand the arches and then take the teeth in the alignment. So after the treatment, the fullness of the face is there. Nice fullness of the face is there with the good cheekbones.
Yeah.
So this is a maxillary torus. So you are doing torus removal in most of the cases or not? No.
No.
In cases of denture, sometimes we have to remove. Okay. If it is obstructing, if it is causing the imbalance in the suction, then yes, we have to remove it. Then torus mandibularis is in exostosis. See, exostosis is a split. Exostosis, extra ostosis, extra bony swelling. Usually bilateral on the medial surface of the body and alveolar process of the mandible. Okay, and generally in the canine premolar region, composed of dense cortical bone with minimal amounts of medullary core. Most common places this and 6th region, mandibular morus. I have a torus mandibularis.
Oh.
So sometimes they keep on increasing and after some time they vanish. Then again they come. So in implant cases, we are not bothered about torus mandibularis. Yes, but if we need a bone graft for bone, we can take bone from here. Good bone, good cortical bone is there in torus. There are some procedures known as alveolectomy, excision of a portion of alveolar process. Alveoloplasty is recontouring of the alveolar process rather than its removal. Frenectomy, excision or of excess of hypertrophic frenum. Frenotomy is release of frenal attachment. See, there is a difference of frenectomy and frenotomy. Okay, just like pulpectomy and pulpotomy. Can you see a tongue tie here?
Yes.
Double lip. It is a redulate fold of mucous membrane that is situated just inside the vermilion border of the lip. It can be congenital or habitual. Usually upper lip is involved. It is just a fold in the vermilion border here inside. So it forms like a double lip. Okay. Then inflammatory papillary hyperplasia of palate. It is a painless, irreversible disease of oral mucous membrane, commonly in hard palate. Primary occurs in complete denture wearers. Okay. Now this is the diagram of double lip. You can see this is not a gingival enlargement. It is a fold of soft tissue. Fold of soft tissue of vermilion border. So these type of things, they usually when we are doing a procedure or some denture procedure is there, we cut it. Epulis fissurata. It is an inflammatory hyperplasia of vestibular mucosa due to chronic irritation from poorly fitting dentures. Then vestibuloplasty, it is a surgical procedure whereby an oral vestibule is deepened by changing the soft tissue attachments. Okay, ridge augmentation, increase in the height of atrophied alveolar ridge. Apulus. See, when this fold is continuous throughout it, then it is called as double lip. Okay. Gingival hyperpigmentation or Apulus fissuratum. Okay. Can you see the arrow?
Yes.
Now, in patient evaluation, chief complaint, history of present illness, history of medical, dental, personal, family, and drug history, examination, general and local examination. Then in local examination, extraoral and intraoral examination, and radiographic evaluation is there. In a extraoral examination, profile, upper and lower lip, nasolabial fold, vermilion border. Then in intraoral examination, hard tissue and soft tissue examination. In hard tissue examination, ridge, form, contour, exostosis, undercuts, tori, shape of myeloid ridge, prominent genial tubercles, then tuberosity area and palatal vault. All these things should be examined. In soft tissue examination, amount of keratinized attached tissue to the bone, areas of inflammation, scars, ulcer and hypoplastic tissues, frenal attachments, attachment of myeloid and genioglossus muscle, tongue size and movement of and position. Tongue size and movement and position, maybe a macroglossic tongue or a micro. In microglossia, we don't have any problem. But yes, in macroglossia, definitely we have problem. Okay. Plus a movement of macroglossia like this. The patient is protruding his tongue while deglutation. In radiographic evaluation, OPG, lateral ceph and CT scans are there. So now after this, what are the various correction procedures? First is most commonly done procedure known as alveoloplasty. The objectives of alveoloplasties, guidelines and surgical procedure and types of alveoloplasties. There are various types of alveoloplasties. Okay, we'll just discuss one by one. So what are the aims of alveoloplasty? Optimal ridge contour for the denture reconstruction. Immediate goal, what is our immediate goal? Preservation of as much as alveolar bone as possible for continued denture stability. Alveolar ridge, the alveolar ridge as broad as possible for maximum distribution of maxillary load. All right. In younger patients, more plastic bone is there, hence more prone to resorption from atrophy. In younger patient, atrophy is more, hence less bone removal in younger patients. Okay. In older patients, the bone resorption is resorption from atrophy is less. In older patients, the bone will not resorb fast because there is a prostheses are there. Okay, but in younger patient, bone will resorb very fast. Surgical guidelines: the cancellous bone resorbs more rapidly than the compact bone. Cancellous bone, which is the soft one, resorbs more rapidly than the compact bone. Hence, more of the cortical bone should be preserved. Delay alveoloplasty in cases of advanced periodontitis to reduce the rate of resorption. Residual alveolar ridge should have a broad surface contact and support for the denture. Hence, we delay alveoloplasty generally 4 to 6 weeks after extraction until new bone forms in the socket. Types of alveoloplasty are: first is alveolar compression. As we do the extraction, we compress the bone. Okay, we compress the socket. That is also known as alveoloplasty. That is known as compression alveoloplasty. Then simple alveolar in case of reduction of labial and buccal cortical margin or less frequently lingual margins. Okay. in a simple alveoloplasty, envelope flap is taken, minimal reflection to the avoid hematoma and pain. Then labial and buccal cortical alveoloplasty, reduction of the outer cortical plate. Disadvantage is excessive resorption. Full thickness mucoperiosteal flap is taken. Okay, and labial cortex is exposed, and the plate is removed using a bone ronger, and then smoothing is done with the bone file. So the sharp bony projections, they are removed in this process. Now, what is Dean's alveoloplasty? It is also called as intercortical alveoloplasty and crush technique. Intercortical alveoloplasty and crush technique. What are the biological principles behind this? The prominence of labial and buccal alveolar margin is reduced to facilitate the reception of dentures. The muscle attachments are undisturbed. The periosteum remains intact. The cortical plate preserved as viable only bone graft with an intact blood supply. Since cortical bone is spared, minimal postoperative resorption is there. Okay. Now in Dean's technique, what we'll do? Intercortical or interradicular alveoloplasty is there. So if we are extracting, we are extracting these anteriors, okay. So what we'll do? We'll just do the interradicular bone remover. Interradicular bone removal. So it can be done with a handpiece also. Yeah, ready?
Yes.
It can be done with a handpiece also. With handpiece, we remove the interradicular bone. Or with chisel also. But mostly we use handpiece because in chisel, the force is not regulated. Then we compress the lingual and buccal bone simultaneously. Basically, buccal bone is compressed, lingual bone is for the support in Dean's alveoloplasty. Second is Obgeweser's technique. In this technique, it is a modification technique of Dean alveoloplasty. In Dean alveoloplasty, the labial bone is crushed towards the lingual side. Okay, but in Obgeweser's technique, both labial and palatal bone cortices are fractured and then they are compressed. See, in Dean's alveoloplasty, this one is the labial one. Okay, can you see the arrow? This one is labial bone is fractured towards lingual. Lingual bone is intact. But in Obgeweser's technique, both labial and lingual bone are fractured and they are compressed together. Like after extraction with burr, we just reduce the inside of the lingual cortex. Okay, we may have to take some cuts also so that we can fracture the lingual bone, or sometimes with the disc burr. Okay, sometimes with the disc burr. Then fracture both the cortices, labial and lingual or palatal. then compress. Now you can see this palatal is also fractured and this is also fractured. And then sutured. Next is torus palatinus, torian exostosis. Okay, you have understood about Dean's alveoloplasty and this of the Weber's technique. Okay. In torus palatinus, a palatal torus has a dense cortical bone with varying amount of cancellous core. Okay, the nodular or fusiform pattern, more frequently nodular with the median grooving corresponding to the medial palatal suture. Overlining mucosa appears stretched and has less vascularity. The scarcity of submucosal connective tissue is there. So surgical removal of palatal tori, the indication is when it is so large to interfere with the speech or traumatized ulcerative overlining mucosa which fails to heal due to poor vascularity, because torus has poor vascularity, then interference with the denture construction. In all these three indications, we have to nivell it down or remove the torus. Surgical technique, the patient is taken under local anesthesia or general anesthesia. If the patient is not cooperative, you have to take it under general anesthesia. Sometimes some people gag since it is a palate. Okay, so they gag. They have vomiting sensations. The median palatal incision is given over the full length of the torus with two short obliquely diverging incisions, like first incision, then two short diverging incisions given anterior and posterior ends to avoid vascular foramina. Okay. Then avoiding penetrating into the nasal cavity if torus is extended posteriorly to the hard palate. See, can you see the incision? First incision is given in the midline, then one extension, and then this extension. So there are two envelope flaps now.
Yes.
On the right and left, there are two envelope flaps, and then these flaps are open. The mucophalangeal flap reflected with great care not to traumatize the thin mucosal flaps, because these flaps may contain the tributaries from the greater palatine artery. Okay. The flaps margins are then sutured to the alveolar mucosa to keep away from the operative field. They are sutured. Like you reflect the flap, just in cases of implantology also, then we give a holding suture. So the flap remains open, holding suture to the opposite sides. Right. Can you see this?
Yes.
Then we have a big torus here. So how it is removed? Sometimes we do with the burr. Sometimes we do with the burr or sometimes with the ronger. Small torus are removed using a chisel or mallet by a sharp blow. Big torus are longitudinal and transfer grooves are made using a carbide fissure burr and then removed with the help of chisel and mallet or burr or ronger. Sometimes nowadays we are just removing with the help of burr only. We take that thick one, the prosthetic burr, thick burr, thick carbide burr, round burr, big one, and just remove the torus. See, these torus, these are removed by chisel, just a sharp blow and remove. But there are chances of maxillary fracture or palatal bone fracture in this. Next is frenectomy. Frenectomy. In frenectomy, this is the lingual frenectomy. Okay, the excess of the frenum is removed. This was the thick band, as you can see, thick band. This is removed with the help of ubiatal blade. Then this is the upper one is sutured back. This one is removed. The portion is sutured back. So now you can see here the release of venom is there. Then patient will have to go for the tongue movement in some days. Okay. Now this is hyperplastic tuberosity. This is a soft tissue correction. Okay. Hyperplastic tuberosity. You have a thick tuberosity and it is interfering with the holding of the denture. So what you do? Make a marking. Okay. Remove the excessive tissue and suture it. Excessive tissue is removing. We are removing the excessive tissue here. Okay, and then these borders are sutured. Sometimes we have to remove bone also. Okay. In this, the excessive tissue is removed, and when we are closing the proximity of the suture, we are just releasing it from the bone. Don't go too deep into the palate because it may injure your tributary of a greater palatine vessel. Okay, so in palatal side, don't go too deep. Yes, from the buccal side, we can reduce it. Maximum stress is on the buccal side. The disadvantage is sometimes it may reduce your vestibular depth also if you have taken a flap, too big flap, so that it is going to the vestibule. So it can reduce your vestibular depth. Now, a ridge extension procedure such as vestibuloplasty. The criteria to be followed: minimal bone height required 12 to 15 millimeters in mandible, but the decision is tempered by the width of the residual ridge of the mandible. In maxilla, reduction of nasal spine may be required to develop a vestibule anteriorly. Anteriorly, sometimes you have to reduce the nasal spine also to get a good vestibule. Okay, intraorally, just these procedures are intraorally. The preoperative consideration for the vestibuloplasty is adequate bone height, but the vestibule mucosa is attached to the maxilla and mandible near the crest of the ridge. Patient's age and physical fitness. Patient age and physical fitness. Evaluation of anatomical factors such as amount and consistency of mucous membrane, amount of alveolar and basal bone, position and tension of the adjacent muscles, presence of bony projection and ridges, and neurovascular foramina. Now, types of alveoloplasty are mucosal advancement of submucous alveoloplasty. The mucous membrane of the vestibule is undetermined and advanced to line both sides of extended vestibule. Secondary epithelialization or reepithelialization vestibuloplasty. The mucosa of the vestibule is used to line one side of the extended vestibule and the other side heals by growing in new epithelial surface. In this, you just cut down the mucosa of the other side, one side, okay, and line it. The other side, it heals by secondary epithelialization. A new mucosa is formed there. Okay. Then grafting vestibuloplasty, skin and mucosa and dermis can use as a free graft to line one or both sides of the extended vestibules. You have cut the vestibule. Now you need to cover the area. So you can use a free skin graft or mucosa graft. Okay. Mucosal advancement or submucous alveoloplasty. First is mouth mirror test. With the lips relaxed, the mouth mirror is inserted into the vestibule. Your mouth mirror is there with a round mirror. Mouth mirror is inserted into the vestibule to the depth prosthetically required. If the upper lip is not displaced upwards or inwards, assume that there is sufficient mucosa for an advancement procedure. Got it? How to access mouth mirror test? Okay. Close submucous mucosal vestibuloplasty, the technique is vertical incision in the midline from mucogingival junction to the upper lip through mucosa only. Then horizontal dissection through lip separating the mucosa from submucosa. Incision deepen to the periosteum in the midline and subperiosteal tunneling is done. So two incisions are given and then go deep into the mucosa. Okay. Right. This is the first incision. Then both the side go both the side using tunneling and dissection. Now when both the sides are tunneled down, okay, this is the alveolar bone, and now you have attained the depth like this in the vestibule, like depth like this in the vestibule. Dissection on both the sides. So this is the upper, see, this is the transfer section like this. Okay.
Yeah.
So this is the depth you are attaining. Okay. And this is the lateral depth from the other side. So wedge-shaped connective tissue between two tunnels is excised. Freely movable mucosa is adapted to the deepen the sulcus with finger pressure. Roller gauze pack in the deepened vestibule to prevent hematoma. Open view submucous vestibuloplasty. The horizontal incision along with the mucogingival junction through the mucosa only. Horizontal incision is given. Mucosal dissection from submucosa as far as onto the lip. Large mucosal flap is mobilized. Supraperiosteal dissection is done. Mucosal flap is secured at the base of the vestibule to the periosteum. The success of mucosal advancement procedure depends on the adequate bone height, amount of freely movable mucosa, and elimination of the surplus connective tissue. So in this case, we should have adequate bone height. Then we can do vestibular deepening. If we don't have a bone height, then vestibular deepening has no meaning. Okay. Secondary epithelialization, reepithelialization vestibuloplasties are first one is Kazanjian technique, then Godwin's technique, lip switch technique, Clark's technique, Obgewizer's technique, periosteal fenestration technique. In Kazanjian technique, the mucosal incision on the lip, large flap of the labial and vestibular mucosa is reflective. Large flap of labial and vestibular mucosa is reflected. Vestibule deepening deepened by supraperiosteal dissection, both the sides. Then mucosal flap is adapted against the periosteum, sutured precautionally to deepen the percutaneously to deepen the vestibule. Okay. So it is deepened like this, and then this raw area is left on the labial side. Okay. Can you see this?
Yes.
Flap is taken from the labial side to the palatal side. Then this is sutured here. This portion where my arrow is sutured here, and this is left raw. Okay, so we get this much of vestibular deepening. Second is Godwin's technique, the modification of Kazanjian technique, the supraperiosteal dissection instead of supraperiosteal dissection, there is subperiosteal dissection. Okay, the rest the procedure is same. The disadvantage of both Kazanjian and Godwin technique is scar contracture on the labial side of sulcus here, with a loss of sulcus depth sometimes. Second is lip switch technique. In lip switch technique, the mucosal flap in the same way as previous techniques, with a free margin in the lip and the base attached to the crest of the residual alveolar ridge. The parietal incision at the height of alveolar crest, parietal flap is reflected from the bone. In lip switch technique, the parietal flap is lifted from the side of bone. The flap with periosteum, connective tissue and muscle is transported outwards and sutured into the margin of raw wounded lip. Okay. Then the mucosal flap is turned down against bare bone and sutured at the depth of vestibule with the periosteum. In Kazanjian technique, the flap was taken away from the lip side. Now it is taken away from the bone side in lip switch technique. Okay. In Clark's technique, it is based on 4 principles of plastic surgery: raw connective tissue surface.
Sorry, hold on. Okay, sorry.
Yeah, it is based on 4 principles of plastic surgery, such as raw connective tissue surface contracts more than when it is covered by epithelium. Raw bony surface cannot contract. Undermining of epithelial flaps to permit reposition and fixation without tension, and overcorrection of to avoid relapse. In Clark's technique, the technique is incision on the alveolar ridge, supraparietal dissection on the desired depth, mucosa of lip undermined up to the vermilion border, and free margins of the mucosal flap sutured through the skin at depth of vestibule. Like in Clark's technique, this is the ridge. Okay, so from the lip, mucosa is reflected and it is sutured into the vestibule. So this area is kept semi-raw because it is a subparietal flap, not a complete flap. Okay, not a full thickness flap. The soft tissue sides of the vestibule is covered with mucosa. The osseous side and the raw parietal surface is left to granulate and evangelize. The patient is into some pain for 2-3 days when the mucosal lining is raw. Okay, so for the raw mucosal lining, you may give a pack there. You may give a perio pack. Okay. In Augmentation technique, the modification of Clark's technique, free margin of the flap is sutured to the periosteum at the depth of vestibule instead of being through the skin as in Clark's technique. Okay, it is sutured in the depth of vestibule. In Clark's technique, it was sutured into the depth of skin of the mucosa. Okay. Then periosteal fenestration technique. The procedure is same as previous, excepted for a modification. The periosteum at the base of newly created vestibule is fenestrated or incised horizontally. The flap margin is sutured into the inferior periosteal margin to fix the mucosa depth in the vestibule. See, these techniques, they have minimal difference. Okay, but various persons have modified the techniques. So all the techniques are, these are one and the same techniques. In all the techniques, either a periosteal flap from the lip is taken or a periosteal flap from the bone is taken. Okay, all techniques are like this but there are minimal differences in the technique. In sometimes the suturing is into the lip wall, and sometimes the suturing is up to the lip wall continuing to the vestibule, just like that. So there are very minimal differences in these techniques. This is the flap, okay, and now this flap will be suturing in the vestibule here. Can you see the arrow?
Yes.
When the periosteum is incised or fenestrated, the healing of the denuded bone is delayed by 2 or 3 weeks. By the time the denudation area begins to granulate and reepithelize, the periosteum covered bone has already grown a new epithelial surface. The differential rate of the healing reduces and relapses the rate. Okay. Grafting vestibuloplasty, skin grafts, various split skin grafts are preferred over full thickness graft from buttocks, upper thigh, inner surface of the upper arm are frequently donor sites. The mucosal graft, from the palatal mucosa we take the graft, okay, and from the buccal mucosa we take a graft. And in xenografts, the porcine skin is taken. So this is how a vestibule is deepened then, and then a skin graft is used to suture both the sides. See, in grafting alveoloplasty, the main advantage, not in the oral cavity, but yes, sometimes the disadvantage is that the graft may reject. Okay. In lingual sulculoplasty, floor of mouth vestibuloplasty types, this is from the lingual side. Anterior lingual sulculoplasty, it is known as Cooley's procedure, and posterior lingual sulculoplasty, such as Cartwell procedure, Turner procedure, and Obgewaser's procedure. This Obgewaser had done procedures in all the fields. In Cooley's procedure, the anterior lingual sulculoplasty deepened the anterior lingual sulcus, release of the genoglossus attachment of and reduction of the genial tubercle if required. Okay. Sometimes it is a combination technique with lingual frenectomy. See, can you see the incision? Here, this is the tongue. Okay. First to the lingual side of the ridge. This is the knife edge ridge here. Lingual side of the ridge, and then towards like this up to the genial tubercles. So this area is left raw. This area is left raw. In Cardwell technique, the lowering posterior floor of mouth along with the reduction of prominent or sharp myloid ridges if required, incision over the crest and subperiosteal dissection up to the inferior border of the mandible, then incision to the crest is sutured back. The mucosa of the floor of the mouth was adapted into deepen the lingual sulcus and stabilize with the rubber tubing using extended margins of lowering dentures. The healing period is 2 to 3 weeks. See, these all techniques, they are with the patient compliance. If the patient compliance is not there, these techniques are useless. Okay. This is the posterior side. Okay. So first, this alveoloplasty is done. You can see a sharp lingual projection here. Alveoloplasty is done. Then from the crest or from the alveolar crest, incision is taken and the this is sutured back, and then it is pressed over this. See, we have extra mucosa, but was the sharp mucosa was covering. Okay, so now the sharp bony projection is removed here. Now this is sutured back again, and this area is pressed. This area is pressed with a rubber tubing or something like that. Okay, so now you can see the flap here, and the vestibule is deepened. The vestibule is deepened. You can see as comparison of the sides. In this side, the bony projection is there. Okay, so this is removed. Now it is after removal of the bony projection. This is the vestibular depth. In Trauner's procedures, the incision at the floor of mouth from third molar area of one side to opposite side supraparietal dissection is done. The mylohyoid muscle is inside to deepen the vestibule, protection of the lingual nerve. Then mucosa and the mylohyoid muscle are secured with precutaneous sutures. If the incision is given like this, this ridge is preserved, incision is given like this. Okay, and then wire is passed and this is stretched here. The button is sutured from the outside. Okay, button is sutured from the outside. So this is an extraoral technique. Like in anterior, we did for one technique, Sachin technique. In Sachin technique, you will always go from outside to inside. Okay, he passes a wire through one hole, then push it back with a U. Okay, and pull the mucosa downwards. And for 2 to 3 weeks, it should be like this. So it adapts to that mucosa. Otherwise, lingual mucosa will pop up. In Obgeweser's technique of combined procedure, it is the combined vestibuloplasty of lingual and cephaloplasty with the skin graft. See, from the buccal side also, and from the lingual side also. Okay. Raw area is there, it will granulate. Raw area is there, it will granulate. This rubber tubing is given over, okay, so that the raw area, this flap is not migrated onto the raw area. Now, ridge augmentation procedures, bony procedures. Type of ridge augmentation procedure are superior border grafting, inferior border grafting, pedicle bone graft, which is called as Weiser's osteotomies, and sinus lift procedures. In superior border grafting, atrophied edentulous maxilla, atrophic maxilla, contouring of the rib. It is taken from the rib. So rib graft is contoured into the shape. Okay, small cuts are made and so that it can be bent. While bending, it can fracture also, but we have to put the graft, so there is no stress about that. Okay, then it is placed between this and hold it with the wires. These are very old techniques, hold with the wire. In mandible, inferior border grafting is there. You have to take flap and expose the lower border of mandible. Okay, and then place a cadaver mandibular graft. visor osteotomy is superior grafting of the body of mandible. In this, what we do, we give a sagittal split of the body of anterior region of mandible with lingual section pedicle to the lingual mucosa. So lingual mucosa is pedicle here, and the buccal mucosa is buccal graft is taken and placed superior. Okay. See, there are two cortices, lingual and buccal. Okay. So what we do, we take out the lingual cortice. Okay, and we just place lingual cortex. This is the lingual one. Lingual cortex upper to the buccal cortex. So buccal cortical is there. Lingual cortical plate is up there. So the height of the ridge is increased. Though it is a sometimes narrow one, but it increases. In modified visor osteotomy, the vertical sagittal osteotomy in the body region and horizontal osteotomy in the anterior region. Rest of the procedure is same. Here in the body region, the vertical sagittal osteotomy is there. Okay, both the sides. And in anterior region, simple horizontal osteotomy is there. In sinus lift operation, the pneumatization of the maxillary sinus and atrophy of the dentulous ridge with aging so assists the placement of osseointegrated implants, the placement of bone graft between the sinus lining and the floor of maxillary sinus and the posterior of the maxilla is there. This is a lateral window technique, which we have already seen in the implantology also. Lateral window technique. This is the orbit. This is the antrum. Lateral window is taken and then graft is placed here and then it is sutured back. Okay. So grafting material for ridge augmentation, they are iliac and rib grafts, then allogenic freeze-dried cadavers in mandible, alloplastic like hydroxyapatite, metallic mesh tray loaded with autogenous corticocancellous or hydroxyapatite grafts. Okay, various autogenous, allogenic and alloplastic materials are used along with metal and mesh trays. Okay, so in this preprosthetic surgeries, what we can conclude, some procedures are very useful, such as vestibuloplasties. Okay, then if we have a thickened mucosa or a thick mucosa, then removal of the extra mucosa or hypertrophic mucosa, removal of hypertrophic mucosa. These things are very important. But practically, the ridge augmentation procedures which was given by previous scientists that take a rib graft and then reconstruct mandible just for the teeth, it is not practically feasible nowadays because the age of the patient, it limits down the surgical our surgical compliance. This is a basic surgical compliance, that age of the patient is there and the patient doesn't want to go for a this type of extensions. Yes, if in case of some carcinoma patient, when the mandible is resected, then you can reconstruct the mandible, then it is justifiable. In sometimes what we do in carcinoma patients, when we know that the mandible is gonna resect here and we have to reconstruct the mandible, then in fibula, we already placed 3 implants in fibula. Fibula is the lower leg bone. Yeah. And during the procedure, after 1 month, when the patient was about to get for the surgery, we just took out this, and the fibula placed with the implant, it was there. So our osteointegration of the implants of 3 months is just we have covered 1 month here. Then after the patient is all right and can be taken into the dental chair, then those implants are loaded. Okay, so though it is a bit difficult to understand this procedure when you are not seeing the live surgeries. And nowadays, these things, the live surgery of these things are not there. Yeah. So what we are doing, we are getting the best materials nowadays, minimally invasive techniques of bone grafting, and also these procedures, these extensive procedures are just for the sake of the knowledge that we should not do these procedures. Okay. That we should not do that.
And after remember the patient, the one with the very reduced reach I asked you about? So we decided to go for a flexible denture. So I've made the design. So I'll show you when it's done.
Yeah, sure. You can record that denture step by step also. Okay, step by step record that denture. Very reduced reach. There is no bone here in the.
Yes, I showed her
in which we have planned for the tilted implants and all.
I don't think. I think it's a no-go.
Basically, it was a chance. It was a chance. Yeah, we have the implants. It was a chance. You know, the patient is not ready with that, so you can't take a chance, because ultimately sometimes economics is there.
Yes.
Patient is there. The patient is saying that I'm bearing this pain and bearing this for 3 months, and after that there is no outcome. Then okay, give me non-surgical one.
And so I just advise her to do the flexible denture, and we'll see how it goes.
Have you started the project what I gave you?
Not yet. So I collected some OPGs, but the thing is,
okay. First of all, start with one OPG. Okay. One OPG and draw the lines and diagnose that. Basically, you have to prepare a diagnosis of 1 page.
Okay.
Okay, size of the teeth, size of the tooth, then size of the mandible, height of the mandible, then war lines, after war lines, where should be the purchase point. That's it.
Okay. Okay.
For one, give me a record of 1, then I'll do the necessary corrections if required, and then you can proceed further. Okay, start.
Okay.
Yes, first.
Okay.
Okay, Friday we'll not have any class. Okay, and we'll have class on next Wednesday.
Okay. Okay.
Thanks,
Okay. Thank you, Doctor. Bye bye. Thank you.